Okay, so let's talk about body temperature and how it varies in response to the location that you're at. Noticing that if you are up on Mount Charleston, it's probably a little bit cooler when you go down to Red Rocks and you're hiking in the middle of summer. So obviously we know that our body temperature changes. We know the changes in the activity, such as when we're at the gym and we're working out compared to being a couch potato. Um, as well as our circadian rhythm varies with our body temperatures. It fluctuates throughout the day. Whether we're sleeping, it's usually on the lower side compared to when we're up and active, it's on the higher side. And gender actually has a temperature regulation as women have a more higher body temperature than men. So we do know where our temperature regulates. I don't need to go into A&P, so that's just kind of a reminder slide of where it's going in case you missed that in A&P, which I'm sure you didn't. We have our heat loss, due to radiation, which could be through electromagnetic waves emanating from surfaces with temperature higher than surrounding area. We can also lose heat due to conduction, which is lost by direct molecule to molecule transfer from one surface to another, so that warmer surfaces loses heat to cooler surfaces. Convection exchanges warmer air at body's surface with cooler air in surrounding space. Of course, our vasodilation diverts core warm blood to surface of body. And decreased muscle tone, exhausted feeling caused by moderately reduced muscle tone and curtailed voluntary muscle activity. We can also continue to have heat loss due to evaporation. The body water evaporates from surface of skin and linings of mucous membranes. If you ever see these big football players playing in the wintertime out at the football fields outside, and you can see the top of their heads are just, you can see all the steam coming off their head due to evaporation. Increased respirations, the air is exchanged with environment through normal process. Voluntary measures, stretching out and slowing down in response to high body temperatures, increasing body surface area, etc. As well as adapting to warmer climates is patients or people that move to Vegas, from New York City here, their body eventually adapts. It's a gradual process, beginning with weakness and faintness, possibly proceeding through increased sweating, lowered sodium content, decreased heart rate, increased stroke volume. And we see this even with our construction workers that come out here in the summertime or even in the wintertime. They're used to below freezing. In Las Vegas, we don't get that kind of a temperature, so their body needs to adapt. And sometimes they are adapting too fast and they wind up in the ER. Our pediatric temperature regulation, these guys produce sufficient body heat but are unable to conserve the heat because they have a smaller body size and higher body surface to weight ratio, as well as their skin is very thin subcutaneous layer. It's not well insulated, so they're unable to really shiver when they are having these episodes. As we get older, everything slows down. Our body circulation slows down. We have a slower vasoconstrictive response and decreased metabolic rate, as well as, again, we decrease in sweating, shivering, and perception of heat and cold. And so everything's always slowing. So you see a lot of the elderly people always wearing sweaters. Even in the middle of the summer, they have sweaters on because of this regulation problem. The body's not able to perceive whether it's hot or cold. Now, fevers are a good thing, believe it or not. It is the body trying to reset the hypothalamic thermostat, basically. It is, fevers are produced by pyrogens, such as exogenous pyrogens. It's a fever-producing substance of external origin, such as our bacteria. It can go into a whole area of endotoxins with the lipopolysaccharide binding proteins and releasing endogenous pyrogens or your interleukin 1s. We also have those endogenous pyrogens, which are produced, like I said, by the interleukin-1s, the phagocytic leukocytes in response to stimulation by exogenous pyrogens and released into the circulation. It induces the fever by acting on the preoptic area of the hypothalamus to raise the set point of the hypothalamic thermostat. And then we also can have fever of unknown origins. But fevers are good. It kills many microorganisms. They decrease serum levels of iron, zinc, and copper if we have too much of it. It promotes lysosomal breakdown and autodestruction of cells. It also increases lymphocytic transformation, phagocytic motility, and augments antiviral interferon production and phagocytosis. So it's a good thing. Our body can go through either hyper or hypothermia depending on what's happening to the patient, but hyperthermia is not mediated by your pyrogens. There is no resetting of the hypothalamic set point. If a patient's temperature gets greater than 100 or around 105.8, that is when we start seeing nerve damage and convulsions with our patients. We don't like to get it that high, obviously, so we try to maintain it and do everything we can when the temperatures start rising, such as cool compresses, Tylenols, etc., those type of things. And if it reaches the body temperature, actually goes to 109.4, patients actually die due to hyperthermia. So there are different types of hyperthermia. You have your heat cramps, heat exhaustion, and heat stroke. Heat cramps are severe spasmodic cramps in the abdomen extremities following this prolonged sweating and losing their sodium. It is common in individuals not accustomed to heat and those performing strenuous work in warm climates. So this is what we usually see when those patients or people come in from the East Coast to work temporary over here in Vegas. And so we have these will wind up in your ER. They do have a fever, rapid pulse, and increased blood pressure that occurs along with these abdominal cramps. Whereas heat exhaustion is results of prolonged high core or environmental temperatures. We have prolonged vasodilation, profuse sweating. They are dehydrated, depressed plasma volumes, the blood pressure drops, decreased cardiac output, as well as an increase of tachycardia trying to compensate for this. Patients come in with dizziness, weakness, nausea, confusion, and probably pass out somewhere along the line. I've seen this when I go to NASCAR. Yes, I am a NASCAR buff. I love racing, and it's here, even though it's March, but you are out in the sun when it's a sunny day and hardly no wind blowing. People are not taking care of themselves. They're not drinking as much, or they're drinking more alcoholic beverages than water. And so they're not really replacing any fluid that they're losing due to the sweat. So these patients, I've seen them collapsing out at the racetrack because of this. So it's heat exhaustion. It's not as bad as heat stroke. Heat stroke seems to be where patients are overstressed with their thermal regulatory center, and the brain just can't tolerate these high temperatures, and so the patient has cardiovascular issues that can eventually stop with these high temperatures and end up dying. What you'll see with heat stroke is the cerebral edema, the degeneration of your central nervous system with swollen dendrites. The kidney tubes, the renal tubulars become necrotic, and again, patients can die. So rapid peripheral cooling will cause peripheral vasoconstriction and limit core cooling, but we have to be careful. We like to do things slowly and not quickly, otherwise we can cause more harm than good. Children are more susceptible to heat stroke. We need to be careful with our kids when they're out there. We want to make sure to limit their time outside and to make sure they have plenty of fluid when they are out there. Their sweating capacity is not as much as what it is with adults, so we need to, again, monitor our children out there. Malignant hyperthermia is a condition that we see with our patients that actually it's an inherited muscular disorder that when patients are exposed to anesthesia, they actually had developed this allergic reaction. So it's an increase in calcium release or decreased calcium uptake with muscle contraction. And so since calcium helps contract the heart, they will have this increase, which will end up causing increased contractions, and the heart can actually work too hard and stop. So there is also an increase in oxygen consumption and lactic acid production. So what happens with these patients have absent reflexes, fixed pupils, quit breathing, and heart stops. So one of the things that we do is we ask our patients to see if they've ever had any surgeries in the past or any reactions to anesthesia so that we can prepare for this. But otherwise, if you had surgery, then you know you can tolerate anesthesia and you don't have this. If you never had anesthesia before, it's one of those things that you need to be alert and awake for when patients come in and complain or state they've never had surgery. Hypothermia, of course, is the opposite. Patients can have CNS and respiratory depression because they're so cold. Ice crystals actually can form inside the cells, causing them to rupture and die. So tissue hypothermia increases blood viscosity and slows the blood through the microcirculation, facilitating blood coagulation. We can have accidental hypothermia, which is commonly the result of sudden immersion in the cold water or prolonged exposure to cold. We can see this with patients that have ice skated or skiing or something like that and fall into a lake or something. Therapeutic hypothermia is kind of an interesting new thing they've been doing, is to slow the metabolism in any type of injury to preserve and not cause any ischemic tissue damage during either surgery or limb reimplantation. There was a football player that had hurt his C-spine on a football field, and so before they even moved him or anything, they started infusing him with cooler IV fluids to help try this therapeutic hypothermia so everything slows down so that he doesn't increase any more further damage along the way. And it turns out they didn't think he'd ever be able to walk again, and he did walk. And they lead it to believe that it had to do with this therapeutic hypothermia fluid volume they were giving him. So that's kind of neat. They call it a cold chill. And anytime you're in the hospital, if you get a chance and you hear a cold chill during your clinical rotations, you may want to take a look, see what that's all about. It's kind of neat. Trauma can lead to central fever, inflammation, increased intracranial pressure, so as well as accidental injuries, hemorrhagic shock, surgeries, and thermal burns. Sleep. So let's just switch over to sleep real quick, because that's pretty much it for temperature. Sleep we all know. Hopefully I didn't put you to sleep in these videos, but it is your major sleep center is your hypothalamus. We do have our wonderful two phases that you've already been taught about, your REM sleep and your non-REM sleep. You go through these 4 stages of what's happening during your sleep. Non-REM sleep is about 75 to 80% of your sleep time. REM sleep is about 20-25% of your sleep time. It occurs every 90 minutes, beginning after 1 to 2 hours of sleep. And we can develop, and patients can complain, or actually it's their spouses that complain of the sleep disorders that may occur, such as insomnia, obstructive sleep apnea, primary and secondary hypersomnia, and then all these other somnambulism, which is sleepwalking, night terrors, restless leg syndrome. Some people even eat in their sleep, which is a concern, and some people actually even fight and argue during their sleep. So we have to be careful. Spouses usually talk about it and bring it to the doctor's attention, because when we're sleeping, we don't know we're doing this. So those are mainly the top 2 classifications that you see. There's also associated with medical or psychiatric disorders and proposed sleep disorder regarding our sleep. We can have secondary sleep disorders, depression, which will make us sleep more, pain. Sometimes some people try to sleep through pain, as well as some type of thyroid disorder. Or we can even have sleep-provoked disorders, sleep stage alterations produced in certain diseases.